Hello, everybody. Welcome to another episode of the Ibarra Exchange. The last episode of this season one, cycle one. We're gonna come back in the middle of August because, as you will see in the website, there's a lot of conferences that Alejandro is gonna attend, and also everybody can use a summer break. So at the Ibarra Exchange, we have specialized clinical psychologists in obsessive compulsive disorder and telemedicine, Alejandro Ibarra from Seville, Spain, and me, Luigi Pesce, PhD trained neuroscientist, where we meet in this bilingual international clinical science debate to speak about obsessive compulsive disorder. This week's topic is very controversial, sort of like the last three, but it's important and it's fundamental that we speak. It's pedophile OCD, known as POCD. So, Alejandro, thank you so much for joining one more time.
Hi Luigi, how are you doing?
Good. It's been a very good week. A little bit hot. Let's get to the bottom of the pedophile OCD because there's a lot of confusion about mental health in general, obsessive compulsive in general, especially when you talk about anxiety and personality, the two OCDs, and about the subtypes. A lot of people wondering, wow, there are subtypes of OCDs, and there's a lot of overlapping with other conditions. So what makes pedophile obsessive compulsive disorder, besides the obvious, so unique? What are like the characteristics and symptoms of this condition?
Yes, first of all, pedophile OCDs are subtypes into the obsessive compulsive disorder, and there is a lot of and many misconception that is into the OCD. This kind of subtype has a very intrusive thoughts around the people that suffer this kind of subtypes are preoccupied by if they are attracted by children. What if I feel attracted or I like some children, so many children. So they are very preoccupied and feel a lot of and very high anxiety. That is the equation and the line of the OCD, and they feel very shame, very guilt. There is the doubt all the time, every single day. The doubt about feel or not attracted by a children, and that is the main thought in that kind of subside.
There's also a lot of questions that individuals suffering from pedophile OCD have regarding that. What if I'm a monster? What if I'm a criminal? What if I have this? There's a level of terrorist anxiety that they feel. It's terrorizing for them. So that scientifically makes me understand that it's very different from an actual pedophile, in which they overlaps a lot with antisocial personality disorder. They don't suffer any remorse, empathy, or guilt. So the fact that the individual suffering pedophile OCD even get to consultation or to psychotherapy, it's a good indication. I think it's a clear distinction from pedophilia. Would you agree?
Yes, exactly. Definitely. People are always asking me all the time, what is the difference between an OCD pedophile and a pedophile? What happens if I'm a monster? I'm a monster, or I'm like the children, and there is a big difference between one of another. I always say that the people that has pedophile don't come to our practice office. So the people that come to our practice office are individuals that suffer, that has many or high anxiety. So they are like in a jail, in a brain jail. So it's a big difference in the manual of disorder, in the DSM number 5. The pedophiles are people that don't feel guilt, don't feel emotions, and they enjoy with feeling attracted by children. It doesn't happen in pedophile OCD. The sufferer that has pedophiles and intrusive thoughts are always preoccupied, every single day is a very terrific thoughts about what if always they are common rituals or compulsion as avoidance. They cannot hanging out or go out to a park or to a shopping or a mall or a school because the triggers are everywhere. So always they are preoccupied and they are suffering by the symptoms, by the thoughts. What if? What if? What if? And it's a big difference. So the videos and all the digital era has closed and has short definitely the term and the evolution between the sufferers and the treatment. Why? Because 10 years ago, 15 years ago, it doesn't exist. So there was like a big problem between the people that suffer and they doesn't understand what happened in their mind. So if I don't a monster what happened in my mind. So when they go to the doctor, to a medical doctor, to a psychiatric, to a psychologist, definitely has wrong diagnosis. So that is not happening today because the science and the era digital and the videos, all the raise to awareness, the information to the IOCDF and my own channel, YouTube channel, has increased the raise awareness and closed the treatment between the person has the intrusive thoughts until they get the right treatment. So that is a good point and a wonderful and a good choice and a good ties. Good news.
Absolutely. The area of digitalization and technology has actually increased a lot of psychoeducation. A lot of people are more aware, they need more help. It has opened the room a little bit for some confusion, but at least there's more information. 10 years ago, when we would have had this conversation, not even pedophile OCD would have like appear as some sort of like a subcategory. And even, I'm guessing that it takes a lot for a person to actually, when they're speaking with a clinical psychologist, as you said, you might not be the first person that they reach out to a specializing OCD. 10 years ago, they go through the medical doctor, a psychiatrist, a general psychologist, a primary care physician. So it would take session 5 to 6 sessions for them to say, okay, look, I have all these rituals. It's actually specific to being attracted to prepubescent children as the DSM-5 class. Now, what I'm understanding is not the case. Now, they can tell you in session 1. They can tell you in the assessment. They are, even though there's a lot of guilt.
Exactly. Fortunately, today, at this moment, we can close the right treatment. So when a person come to our practice office or in this moment by Skype or through Skype or through WhatsApp, when they come or make the phone call, normally they know what happened with their minds. So I'm not a pedophile. I'm suffering by these kind of subtypes because I watch your video, because I watch your article, because I watch your news or your information. So I know what happened. So I'm not a pedophile. I'm suffering by POCD. So I need to get the right treatment. And so I need to get to get help. So this information, this 10 years ago or 15 years ago, it never happened. So there is a wonderful.
It's definitely one of the milestones that we can thank technology, that people don't have to suffer in silence anymore. As 20 years ago, there's always been the mental stigma, the taboo when we talk about mental health, the stigma of mental health, and this is a even bigger stigma, 2 layers of a bigger stigma. One, the ritual, the embarrassment of someone feeling OCD, inability to explain it, of how they sort of get trapped in a maze of their own thoughts, a jail they created to themselves. But now a 3rd layer, which is a lot of those thoughts are the fear of being attracted to children and the worry of what if they become themselves a monster. we spoke a lot about the psychological symptoms. Are there any physiological, any physical symptoms that come along with it? Anything that happens when we talk about the autonomic nervous system and the sympathetic, the fight or flight response? Whenever they see a kid, do they get worried? Do they get pleasure? How do they respond to it?
Yes, remember that what happened in all the OCD subtypes that has manifestation with POCD or with non-ritual motors, happened that all the sexuality is not working very well. So they have not just thought or compulsion, they feel some sensation like groinal response. Groinal is like a warming up or checking or vibration in the groinal, in the genital area. So it's very confused to a sufferer, because groinal is an involuntary sensation, but to them it's like a proof, but it doesn't prove anything. It doesn't prove that that is a big problem with not just thought or compulsion, even with sensation. So definitely ERP has improved and get with the right treatment, with the individually ERP, it gets better with some session and with some work.
And these feelings of this groinal response that they feel involuntarily and automatically, of these sensations that happen in both men and women, it's in parallel with the guilt and the anxiety and the suffering and of having of being attracted. Like these two completely opposite symptoms, one psychological, one physical, they happen at the same time. They had the groinal response in combination with the fear.
Yes, definitely, it's happening at the same time. At the same time, it happened together. For example, the thought, I'm a monster. I really feel attracted by children. That is the thought, the rumination. After that, anxiety. After that, the compulsion, avoidance or ritual compulsion, or an imagine to get down the anxiety. And after that, at the same time, the groinal response. But if I'm feeling something that happened down, why? What happened with my groinal? That is the proof, and that is very confused. So it happened all together, not in all the patient. Be careful because the video are to raise the awareness, the information, not to prove anything, not to through the video get to my right treatment, not to replace therapy.
We're not a diagnostic tool.
Exactly.
We're not a treatment. Neither is Dr. Google or any website, but yeah, absolutely.
Exactly. So, but it happened in some of the clients or in some of the patients, but not in all, but in some it's happened. So what happened with the groinal? The person and the people has to get the right treatment to decrease the anxiety level in that area until that disappears. So it happened with work and with ERP.
Absolutely. Just like in the last two episodes, there's a lot of neuroscience information missing because we don't have access to this particular type of individual, especially the subtypes that are very, very new. However, we don't even, just like you said, pedophiles don't get into a consult. Yeah, pedophiles don't get into a clinical study, doing an MRI or a PET scan or a DTI or EEG of how the pedophile brain works. It's a crime. And there's not much we can do in the terms of understanding how the cortical networks in the brain happen in these individuals. What happens at the subcortical level? Is it the limbic system? Is it the autonomic dysfunction? But I wonder what do the stats say in terms of from the clinical point of view? Do you see any difference between genders from that they suffer POCD? Is there any difference between individuals that are married or single, 18 to 80?
Yes.
Is there a gap in this one?
Yes, there is a misconception and a myth that think that OCD respect gender or anything. Definitely, it doesn't respect anything. In POCD, we see in our practice office in Cinco Alejandro Ibarra here in Seville, treating patient in all this pain and in Latin America and United States, that there is no difference between gender, age, race, or anything. Because POCD is a subtype. So we see in our practice office at the same times in men and in women. There is no difference in gender. So what happened with the teachers in the school, men or women? It doesn't respect with race or with gender. What happened with the nurses? Anything, not happen a big difference. So it's a like equal between race, gender, age, and just we have that you said a data. We don't have like a conclusion because it doesn't exist. It doesn't exist.
Yes, whenever there's something related with pedophile portrayed in the media, it's always a man. And whenever you see in television, in a movie, in a series, you cannot even subconsciously you think like a pedophile individual, you automatically think of a man. Another disclaimer, it would be very important, is that nothing in neuroscience or in psychology or anything related with behavior is 100% a certainty or 100% a fact. All we can do is generalizations based on quantitative data with significantly differences, but neuroscience, there's a lot of variability and a lot of heterogeneity between every disorder, every condition, just like there is in genetics and microbiology. We're seeing with the pandemic that every single day, a lot of studies differences. It's really has relied more on the individual. There's a lot of companies and a lot of strategies to focus more on the individualized treatment because there are things that you cannot general. All the statements and arguments we make are that we're seeing in most patients is being reported in most of the cases, but it's never like 100% for everything. I had a really important question regarding like what is a primary fear in these individuals, at least from a general point of view. Is it the fear that they see themselves as a monster, or two, is it the fear that they're attracted to children, or three, it's a combination of both, or four, it could be something else? What do you see? Like, what do they care more? What makes them more anxious?
As all the subtypes in OCD, POCD is not an exception, because they feel very anxiety and they very preoccupied by the content of the thought. Because remember and don't forget that the thoughts are ego dystonic. So ego dystonic. So they think, why I have this kind of thought? If I don't really feel attracted by children, but I feel or I have my idea of the thoughts all the time. So they are very preoccupied by that. So not just by the thoughts, also by the imagine, or when they go to go out to a bar or anything, what happened when they see a small children with 10 years old or 12 years old? What happened? That they feel the anxiety, they feel so nervous, that just imagine or just see a children, they feel so nervous, so they have to avoidance that situation. They have to go out to another bar, to another place, to another anything. So there is the big problem, because they feel that they are not, but they think the opposite. They think all the time with this idea. So they know that are something wrong in the brain with the thought. So when they go or come to our practice office, they just need to help. I know what happened with, I know what are something wrong with my mind, so I need help. I need to do something that calm or that keep down my anxiety and my thought disappear. So ERP, once again, ERP is the solve the problem.
And I assume these are the type of individual that's the individuals that do not obstaculize treatment. That on like what we spoke last week, that there's a lot of micromanagement of the clinician, of the typical patient that you say it's the breath of every day, like it's what happens every day. You have a patient telling you how you should conduct your treatment. It comes with a rigorous and robust like personality of the overlapping of obsessive compulsive personality disorder with obsessive compulsive anxiety disorder. But I will imagine that in these one, patients are sort of desperate to get better as fast as possible, as soon as possible, as early as possible, and they'll be like, ERP is not an obstacle. Cognitive behavioral therapy is not an obstacle. They actually, sure, let's go.
Exactly. Definitely ERP works and it's wonderful because works and require work. But what happened with POCD? In our practice office, we have seen that individuals with POCD and harm OCD get improved faster or little faster than people that are suffering with HOCD or ROCD. But it's not a rule. Once again, it's not a rule. We can say that individuals with POCD and harm OCD go faster than, because it's not a rule. That we have seen in our practice office with work and with frequency of the ERP, and individuals then have the courage to do the imagine with ERP, go faster with the right treatment and go faster with the solution to solve the problem, to improve the quality of life and all the results. But once again, it's not a rule. Be careful with that information, because many people that watch our videos say, Alejandro, you said in one video that, and that is not really, that is not a rule. And once again, that is science, and the people has to manage the uncertainty and everything to get the right treatment and little by little go to the right and get better.
It depends on the case. As we always said in the Spanish video, every case is a universe. Just to have a couple of last quick questions regarding the incidents and the strategies. You said that these individuals avoid a lot. So like avoidance is part of their first compulsion, their first action. So they have the constant thought, the constant thinking, what if I'm attracted to children? What if I'm a monster? What if I'm this? They also have the constant compulsion of never actually materializing that, thank God, that action, but actually more of avoiding being in places like children might be around, such as like the park. But what if they have their own children? What if they're married and they have their own children? Because as you said in the previous video in Spanish, OCD, it's not related with a trauma. It's the one psychological disorder that it's not like it comes rapidly, comes aggressively, but it's not related. It's not PTSD. It's not like you had a major drastic event that happened. So.
Definitely, OCD is not PTSD, so it doesn't come. It's multifactorial, multicausal, genetic, hereditary, and behavioral. Okay, so it's not a PTSD, and it's not a cause effect about trauma. So that's a good question, because we have many clients that the problem is with her or his own daughter, nephews, or family, because children are always, or maybe in many cases, in family. And what happened with my cousins that are children around 8 years old? What happened with my nephew? What happened with my daughters? Okay, so avoidance is the first compulsion. It's like the mother of compulsions. So they cannot see the family in many cases, many times. So the challenge with ERP is to get close to their family, to see their family, to see the daughters, their cousins, to take a breakfast or a lunch or whatever with their families. That is a challenge, but the sufferers has many like they want to get better, so they work very hard with ERP, and that is a very good news, because exactly because they want to get better, so they work and push through, always going forward to get better. So that is the reason to get the right treatment.
that in it's the same thought process that you said we talked last week when we talked about relation OCD and how about the person actually avoids and think it's a really good, solution to just not seeing move to their friend's house or rent an apartment by themselves to the basement of their parents' house and avoid their partner for a while. And you last week you said no, that shouldn't be the case because it's just going to increase the anxiety. So it's the same in these situations. Individuals with POCD tend to avoid being in places with children for their normal and rational fear of not hurting them or not, materializing that their obsession. But at the same time, you as a clinical psychologist, as an ERP treatment with the cognitive behavioral therapy, it's avoidance. You see avoidance as a compulsion, and it's something that it worsens the condition. It increases anxiety, and that's something that you try to target and diminish, not avoid it, especially if they have their own children.
Yes, avoidance is the first compulsion, but remember that the ERP works progressive. It's like go to a swimming pool. So you don't go to the deep part of the swimming pool with 200 meters down. No, we go to the maybe 1 meter or 2 meter, and after that we are going to work and get improved with the treatment and feeling better. And it happened the same with ERP. So it's progressive. It's progressive to see the children, after that to touch the children, to take and keep the imaging with children in their minds. For example, there is progress. But the results are very positive. Very positive, because remember that recovery is possible and there is no an exception. No one is not an exception. So the people have to know or to believe in ERP therapy and to start the treatment, because recovery is possible at this time and this moment.
I think two major positive things that we can lead is that thanks to this technology and rapid increasing information, there's actually more psychoeducation. People are more aware, which actually brings them closer to treatment as opposed to 20 years ago where they suffered in silence and suffered, and if anything, they get rejected from both the society and both the scientific community. And the second is that thanks to ERP, in these individuals that suffer, unfortunately, this specific, there's a lot of positive outcomes that occurs. It's actually, they're motivated to get better, and you see in your practice, and the psychologist working in your practice every day. So technology brings a lot more information, and this specific condition actually improves very fast if they are aware and follow the treatment.
Exactly.
So,
absolutely.
Thank you so much from joining us from Seville, Spain, here in New York. Wish you a happy summer. We'll see you back again in the middle of August. Good luck with the conferences, and thank you so much for talking about so many important, controversial, but needed topics.
Exactly. Thank you, Luigi. Thank you. See you to you and all the people around the OCD community after middle August. We have a stop because some conference with Mexican people, and after that we come again with more information, with more videos, and with more awareness, OCD, and information. Okay, so
absolutely, and we're putting all that information in the website, the Ibarra Exchange website, all the conferences that you will be attending. And hope to see you soon. Have a great day. Thank you so much.
Thank you. Bye bye.
Ciao, ciao.